Hi everybody, we're going to talk today about seizures, so I hope you're ready. We're going to try to make up for a little bit of lost time. This is intracranial regulation. We did already have a class for this, but since it was on the 10th, everyone was a little preoccupied. So we're going to talk about seizures, the kinds of seizures, and epilepsy. Just like we did in class, we talked about your text having a pretty good, pretty decent verbiage about definitions, mechanisms, all that stuff about seizures. So we're going to start talking about what is a seizure, what is epilepsy. Anytime you've had two or more unidentifiable seizures that they don't know the reason for, they're going to diagnose that as epilepsy. A seizure is really an electrical storm, so to speak, of abnormal electrical activity in the brain, causing involuntary movements or behavior, and it definitely has sensory alterations with it. A person can have a seizure without having true epilepsy. There are febrile seizures and there are other seizures, but we don't really get into that in this content. The incidence is high. 1 in 10 people on Earth will have a seizure at one point in their life. We talked about the patho and the triggers in class, but I just want to make sure you see fatigue, alcohol, hypoglycemia, menstruation. Please know that this is slide 10, and I need you to know that slide. Lots of other risk factors. Oh my goodness, there's so many. Well, I need you to know slide 11 as well, because there's tons of risk factors here. What happens during a seizure to the body? It is so taxing on a body when a seizure happens. So I would definitely read through this slide and the phases of it. There's something called a post-ictal phase after a seizure. So if they say the patient is post-ictal and has been for 2 to 3 hours, pre-ictal would be the aura that some people have an aura right before they seize. They know to sit down, or they know to drop what they're doing and try to get seated, or they may say hey, and all of a sudden they have a seizure. Not very many people that have seizures that I've worked with have true auras that are predictable and that are consistent. Make sure you know post-ictal. What a post-ictal? Usually a patient who's post-ictal is very lethargic, very tired, just may have a horrible headache. Tonic-clonic seizures are a seizure that used to be called grand mal seizure or a generalized seizure. It is the most common type of generalized seizure. Loss of consciousness may happen. They may cry out. They may urinate on themselves. They don't have any memory. This is not just by and large the case. This is individualized. It's like a belly button. Everybody's is different. So just know that there are times that some patients are going to have all of these, and some patients are going to be like, no, I don't do that. I just have a seizure and this happens. So they're individualized. An absence or an absence used to be called petit mal seizures. They may experience a brief loss of consciousness. Momentary. Or it may be a little bit more than that. The patient is literally just absent mentally because there's a seizure going on in their brain. It can be mistaken for daydreaming or just not paying attention. The patient may feel like they're losing time. The patient may drool or slump or fall, but typically it can be any of that. We talked about other types of generalized seizures. These are the less common than the tonic-clonic. Then there's focal or partial seizures. We didn't get a chance to talk about this, but the videos are really strong data for you to look at. So there's simple and complex with these focal seizures. The patient with a simple focal seizure will remain conscious, but a complex focal seizure, there may be loss of consciousness or a very lethargic state or a very obtunded state. They may stare blankly off. They may have jerking movements of a certain part of the body. It's just very interesting. You need to read your text on this. The concern here is, how do we care for the patient that experiences this? How do we teach the caregivers and the patient how to care for themselves after a seizure, or to prevent seizures, or how to care to make safety in the home for a seizure patient? There's certain lifestyle modifications there. And a status epilepticus, we did talk about this. Remember, everybody, it's a medical emergency. Airway is priority. And then we may need to give rectal or nasal diazepam or IV push if they're in the hospital. And we may need to repeat that if it's not effective the first time. If a seizure is not stopped or treated, it can lead to respiratory failure, arrhythmias, brain damage, aspiration. It can be very bad. So collaboration between the healthcare team, that's the nurse, physician, family, and client. Children, that would include teacher, the school nurse, and other adults that are caring for your child, even the bus driver. If your child is a seizure patient and rides a bus, I mean, that bus driver should know and know what to do. All right, diagnostic tests for a diagnosis of epilepsy or seizure disorder of any kind. It's going to always have the EEG. Now, make sure you see EEG and not EKG. And EEG is an electroencephalogram. Try saying that 3 times. That is definitely something that is going to happen either in an inpatient setting, or sometimes they do a 3-day outpatient or longer EEG monitoring. We would do an MRI to make sure there's no abnormalities or growths in the brain. A lumbar puncture would be done for someone who might have meningitis or some kind of infectious or viral process of the brain. Drug levels, absolutely. We want to make sure that A, you don't have any illicit drugs, but B, that if you're taking an anti-seizure medication, that it is therapeutic. We would test your urine. Oh my goodness, people. I'm going to ask a question. Why would we want to test the urine of a seizure patient? You need to email me and let me know. All right, there are some tracings from an EEG with epilepsy spikes. I wish I had more time to talk about this. All right, epilepsy drugs. We know that the most common kind of hydantin in the world that's prescribed is a phenytoin. Phenytoin is Dilantin, and it is absolutely prescribed by the boatload. It is cheap, it is effective, and they can monitor it with the therapeutic drug level. It's not effective for everybody, but it is very effective. Also, barbiturates, like the diazepams. This is phenobarbital. Phenobarbital is not in the PAM family. It is a barbiturate. And if you don't know, a barbiturate is what people on the street would call a downer. It's going to mellow you out. It's going to chill everything. It should not be used during pregnancy. And it does have a therapeutic drug level. Valproic acid, which is Depakote. Carbamazepine, which is Tegretol. Don't make me say it. Levetiracetam, Keppra has no associated blood level, but somebody has recently told me that they actually do have a blood level now associated with this. Gabapentin and pregabalin Lyrica, both are used as adjunct treatment, okay? Adjunct treatment. I don't believe there's anybody who has a serious seizure disorder and who is only prescribed gabapentin. Every client taking anti-epileptic drugs may not have a seizure disorder, okay? There are off-label brands. You may bring in a patient one night who says, yeah, I take Klonopin, or I take gabapentin, or I take Depakote, but I take Depakote for X. I don't take it for seizures. Or I take Topamax, but I don't take it for this. You also have the PAM family. You have Klonopin or clonazepam, diazepam, and lorazepam. And you might even have alprazolam used as adjunct therapy. The benzodiazepines suppress the propagation of seizure activity in the brain. It chills the brain out. It's not the most effective, but it is fairly effective in chilling out those seizure activities. Surgical management is a very, it sounds very promising, and there was a time that everyone was thinking we can cure seizure disorders with surgery. But unfortunately, patients with epilepsy don't respond well to this therapy, sadly. The pre-surgical workup is very comprehensive. It's high risk, and it is only done in certain medical centers in the world, or in the United States and in the world. There is a vagal nerve stimulator that can be used. It's in your book, and it's covered in your book as a possible treatment modality. If you were at your wit's end and you just were trying to get those seizures to stop, a VNS lead would be implanted with a vagal nerve stimulator, and it would be, you'd hope that it would be helpful. Some people have found help with this, but it is simply not something that is one size fits all. Ketogenic diet is a therapy that is coming very much in vogue. It has been in vogue for a while now, but it's in vogue with seizures and seizure disorder because evidently this has proven effective with several studies behind it now, that this is actually reducing the amount of seizures that some seizure patients, experience. So I'd like love to see the data on this. If you don't know what a ketogenic diet is, I would really think that you should look that up. The nursing assessment, you definitely want to do a neuro exam. Now, if you don't know what's involved for a neuro exam, I need you to think through this, and I need you to go back to your textbook and find out what a neuro exam is. Make sure you go and look up your neuro assessment and make sure you know that it's not just alert and oriented times 3. There's a whole lot more to it. You would assess that patient who has epilepsy, ask them about their seizures, ask them about their meds, ask them what they know. With the focused seizure assessment, you are going to be definitely wanting to know everything. Did you have an aura before it? Did you urinate on yourself? Are you having a headache? What did you do after the seizure? How did you feel? How did you know you had a seizure? Was someone there with you? All of these things. How long did it take you to get back to normal? Did it take 2 hours? Did it take 4 hours? Did it take the next day? Nursing problems are very self-explanatory. Please look at slide 37. That's the one we're on. And really know that when we're talking about nursing diagnoses or problems, airway and safety are always going to trump you as the most important for an actual seizure that's ongoing, like a seizure that's status epilepticus or something that's going on now. Planning, this is the same stuff. Implementation, yep, okay, that's great. This page number, I believe, is one that I doctored up and is current. If not, let me know. But I think we're good. Pediatric lifespan, all that good stuff. Pediatric considerations are very heartbreaking to read about, but you really do need to read about it. And evaluation, of course, is in there too. Okay, guys, it's been 12 minutes. I've gone over everything I know to give you, and I will definitely be talking to you about this before test 3.